Good morning, ladies and gentlemen, PSK members who've joined us today. Other cadres that may have also joined, you're very welcome. Our distinguished panelists, our speakers and moderators, I'd like to welcome you to this session. My name is Daniela Munene, and I'm the CEO of the Pharmaceutical Society of Kenya. And it is my pleasure to host this session for you today. This is, I think, the 14th session in the COVID-19 webinars that we began earlier this year, where pharmacists share their experiences in managing the pandemic. And it has been a very insightful process and very well attended with very engaging sessions. So we have a good session lined up for you today with some very experienced pharmacists. But first, I'd like to introduce to you our moderator for today, who will take you through the program. Our moderator is Dr. Michael Mungoma, who is well known to many of us. He is the Dean of the School of Pharmacy at Mount Kenya University, that's in Thika. And he's a member of PSK, an active one, I might add. He's in the NEC, that is the National Executive Committee of our Governing Council. And he's also a member of the PSK COVID-19 Response Task Force. Karibu sana, Dr. Mungoma. Please say hello to the participants.
Good morning, everybody. Welcome to the webinar.
Asante, Mike. I will hand over to you now. Please take us forward. Asante.
Thank you, Dr. Daniela, for that. Welcome again, everybody, to our webinar today on the 9th of September 2020. We are really appreciative of your commitment to participating in these webinars. Before I continue, there are a few ground rules and announcements that I want to make. One, that participants are going to be muted during the entire course of the webinar. You are asked to ask questions through the Q&A tab that is at the bottom of the window. Questions are going to be addressed by the panelists at the end, that is later in the program. For PSK members, if you haven't already done so, subscribe to the PPB portal today for today's webinar so that you can get your CPD points. For PSK members, kindly note that CPDs will be awarded to paid up members only. So that's very important, and we really appreciate your continued support. This webinar is being recorded and the audio will be made available on the PSK's YouTube page. For those of other cadres, including pharmaceutical technologists, you're also encouraged to subscribe on the PPB portal for this webinar for you to get your CPD points. Meanwhile, PSK also is going to collate a list of all those that participated. And there's a way that is coordinated together with PPB to ensure that everybody who attended gets their CPDs. Mao, next. So just straight on to our speakers, I'm going to introduce. Our first speaker is Dr. Ruben Mogoi. He's a clinical pharmacist at Aga Khan University Hospital in Nairobi. He's a former lecturer of Mount Kenya University and Kenya Medical Training College. He is a seasoned pharmacist. He's an alumni of Dr. MGR Medical University, India, and University of Washington. He is a member of several professional organizations, including the Pharmaceutical Society of Kenya, Nairobi branch, Bioethics Society of Kenya, SIDP, HOPAC, and Kenya Society of Pain Management. Our second speaker is Dr. Kagwa Gichuki. He holds a master's degree in clinical pharmacy from the University of Nairobi. He has undergone a renal pharmacy preceptorship course at the East African Kidney Institute. He has a special interest in non-communicable diseases, where he offers medication therapy management to patients with chronic illnesses. His passion is patient-centered pharmaceutical care. He is the newly elected chairman of the Hospital Pharmacists Association of Kenya, HOPAC. Welcome our guest speakers. Our program is as follows. At 10 minutes past 11, we are going to have our first presenter, that is Dr. Robert Mogoi, to talk about trial therapies in the treatment of SARS-CoV-2. Thereafter, we're going to have Dr. Kagwe Gichuki presenting on management of COVID-19 in special populations. And then after that, we're going to have our question and answer session, with myself being the moderator. Again, I want to encourage everybody to send in their questions during the presentations so that we can look at them and start attending to all the questions during this session. So I want to move straight to the first presenter, that is Dr. Ruben Mogoi, to do his presentation. Dr. Ruben Mogoi, you could share your presentation and proceed. Karibu. Dr. Please unmute yourself and put it on PowerPoint presentation. Thank you.
All right. Good morning, everyone. Thank you very much, Dr. Mungoma, for that good introduction. I'm very pleased to take part in this webinar series, PSK webinar series, regarding COVID-19 trial therapies. As you know, COVID-19 has been part of us now for the last almost 6 months in Kenya, and of course, almost now a year. It's almost gonna be a year now in the entire world. So today our session is gonna be very brief from my end, if I may say. I'll just be tackling some of the therapies that are being used to treat SARS-CoV-2. And some of these therapies, remember, are not conclusively or proven to be the treatment, but rather they are trials, hence the title, trial therapies, as we've written it. So to move quickly, our key focus area today, as I've said, it's going to be very brief. We'll look at a bit of introduction of what we're going to talk about, and then we talk of those suggestive trials that are being used world over, and even in our country in Africa. We tackle some of the latest updates of these trials, and what do we have to monitor, and some of the recommendations of what do we recommend as a profession to these trials which are being utilized world over. And lastly, we'll look at our role as a profession or as a society. What do we have to offer, or what is our take, or what is our position, or what is our input to this whole thing of COVID-19 matters, medication, therapy, and so on. So the bit of introduction is a disclaimer, really, because it's been repeated over and over by many speakers in many webinars that the trials that we present in this session are not proven, neither are they specifically approved to be the treatment of COVID-19. Rather they are investigational, they are trials which are constantly being updated, are constantly ongoing. Researchers world over are burning that midnight oil to really try to find a cure for COVID-19. So this should not be misconstrued as as a proven treatment for COVID-19 rather than an investigational trial of these therapies. And this information is subject to update, regular update. As we know, the information is rapidly evolving and the information is dynamically. Every day you wake up, you find there's a new journal after journal of these therapies and other therapies, which maybe I'm not going to mention, but we have an information overload in these past few months regarding matters COVID-19. And to put it in short, that the information that we're going to share do not really replace clinical judgment from our other healthcare practitioners, the ID consultants, rather to enhance and to supplement the practice so that we are able to tackle the COVID-19 together. So it should not replace, it should not be misconstrued as the suggestion that is to guide practice, rather to enhance practice. And so it's important for us to be able to ensure that patient outcomes and response should be closely monitored so that we do not end up shooting ourselves in the foot thinking that this is a proven therapy rather than a suggestive one. So some of the therapies that I'm going to gloss over today, you can see they're not so many, but when you look, for those who are constantly reading journals, you find there's so many trial therapies out there, but we cannot mention them in such a session as a short session. So I'm going to gloss over the important ones, the ones that we have been suggested to have shown effectiveness or quite good efficacy when it comes to COVID-19. And we have the direct antivirals, including remdesivir, and we have HCQS, which in recent weeks has been expunged and no longer in use, but still under controversies. And then we look at the supportive care, including the corticosteroids, of which now people seems to it seems it's like guiding the practice. In every patient, you'll find the corticosteroids here and there. And then we'll talk about the immunomodulators. We'll talk about the immune response modifiers, including azithro and tocilizumab, in a very brief and short session. So welcome to this session as we tackle these trial therapies. And I'll start with the direct acting antivirus, and we'll look at remdesivir. Now, remdesivir has generated quite a number of reactions, and it has been touted to be the most promising antiviral agent for critical care of COVID-19. And then the biggest reason to this is because it is a broad spectrum antiviral, and as we know, it's been used or tested for the treatment of Ebola previously. And the FDA emergency approval that was given a few months ago was for children and adults who are hospitalized with moderately severe illnesses. As you can see, I've underlined hospitalized and moderately severe, that if patients are severely, then if patients are mild, then there's no use for remdesivir in those cases. When you look at the particulars for remdesivir, the dosages which have been used in most of the trials that we've looked at are the loading dose of 200 milligrams, and then continuation of 100 milligrams daily. And children's also, the dosage will be body mass based of 5 mg per kilograms per dose start, and then 2.5 a continuation dose. This particular drug is available in Africa, in Kenya, and it is available in 2 formulations. We do not have an oral formulation for remdesivir. So we have a solution of 5 mg per ml vial, and we've got a lyophilized formulation of 100 mg per ml. So for the start dose, the patient will be given 2 vials, and then a vial each day for a period of 5 to 10 days. Now, as I've said, orally it's not available because it's almost complete fast-pass metabolized, and it's only eliminated 70% renally. Now, best way to administer this medication is by infusion of not less than 30 minutes, but mostly we give it over at least an hour. So it has to be reconstituted with water for injection, and then diluted to make a concentration of 5 mg per ml with normal saline, 0.5%, and then of course infused. After infusion, there is a flush of 30 ml of normal saline. And then of course the diluted solution can only stay in the fridge. So after reconstitution, dilution should be used immediately. Remdesivir, now some of the key important toxicity that we need to look out for is the elevation of LFTs and rarely kidney injury. So you find in some patients, you'd find up to 3 to 5 times the upper limit normal elevation of LFTs. And funny enough, some patients, I've seen a number of patients who would have no elevation of LFTs whatsoever. But LFTs is one parameter that we have to look out for when it comes to remdesivir, and it's a common one for the number of patients that are on this. But the good thing is that on reverse, when or after stoppage or after the duration of dosage has elapsed, the LFTs kind of normalizes or kind of comes down. And some other side effects will be constipation and pain in the extremities, and of course, in the area of infusion, there will be phlebitis. Some of the drug interactions so far is, of course, avoid totally when using hydroxy. If a patient is in a long use of hydroxychloroquine, should avoid the concomitant use of remdesivir together with HCQS or CQ. And of course, those inducers, cytochrome inducers, including the drugs like phenobarbital, would decrease the serum concentration of remdesivir, so should be monitored closely. In special population, safety in pregnancy is still unknown. Very few women have received remdesivir through this compassionate program. And of course, these women should not be denied care if they seriously do need remdesivir dosage. Dose adjustment in kidneys, patients with GFR of less than 30 or receiving renal replacement therapies, including the hemodialysis, it's not recommended. And of course, it can be given at any point of patients who are severely and hospitalized with COVID-19. The monitoring bit of remdesivir, I've already mentioned it, it's just repetition really. 5 times upper limit should not be initiated at all. And if a patient has got 5 times of these LFTs, the upper limit should be discontinued. So when the patient comes in and the LFTs have to be checked even before remdesivir is initiated. And if they are found to be normal, then that's a go ahead. And if they're not, then it should not be initiated. And if in case it could be restarted, if of course the LFTs do normalize, it could be continued. If we look at some of the updates so far regarding remdesivir and COVID-19, we've got quite a number of controversial updates from the FDA. When you look at this particular suggestion that there is a study which is going to evaluate the efficacy of safety of remdesivir in the treatment of coronavirus in the outpatient setup. Quite shocking, really. It's bemusing considering how do we get to test, how do we get to give remdesivir to outpatients, considering many things, including the cost implication. And there is another update recently from the FDA, which wants to broaden its emergency use. Actually, it has broadened it to include hospitalized patients for treatment of COVID-19. Remember, these are any kind of patients, not the ones who are moderately severe. It's talking about expanding it to all patients positive of COVID-19, but just hospitalized. Now, this has brought out sharp criticism and reaction from the scientific society, really, because now it has erupted questions like, is it evidence-based? What is the rationale, really, of giving patients with mild asymptomatic COVID-19 remdesivir? And we know, even in our own setup here in Africa, in Kenya, mild cases of COVID-19 are rarely hospitalized. Now we have the home-based care, but now this particular update seeks to give patients who are hospitalized with mild symptoms or mild asymptomatic COVID-19 remdesivir. So who will admit COVID-19 patients with only a fever and a cough just to receive remdesivir? Is it being pushed out? Is it what is really informing this particular update? Is there any conflict of interest? You know, we saw recently there is a board member of FDA who actually is pushing for this. So a lot of controversy around this, and we have to learn from the lessons from HCQS. Now, as important as it is to ensure that we give the best practice and best care to our patients, it should not at any time come to the expense of the public safety. This medication does not come cheap either, because a vial of this goes for about between 10 to 15,000, and that's quite costly. So I don't think this this broadening of use of remdesivir will go down well in most of the researchers. Now, the previous research has found that, as we've mentioned, that remdesivir has the best outcomes in patients who are not receiving oxygenation compared to standard of care. And it has gone to define what is a mild illness, what is a moderate. When you say it can be given to patients with moderate, severe COVID-19, what do we really mean? That is patients who do not require really oxygenation, and patients who can be able to survive and who are using room air to see at sea level. So moderately ill illnesses. And now some of the trials, there's this trial which sought to differentiate between a 5-day course of remdesivir and a 10-day course. Over the past few months, we've seen that a number of patients would receive only a 5-day course and not a 10-day course. And this particular research found that hospitalized patients with moderate COVID-19 who are randomized to receive a 5-day course of remdesivir was significantly better, had better outcomes compared to those who received a 10-day course. And the odds ratio for 5-day course was 1.6. And when you look on your right, the peak discharge were done on the 5-day course. On day 5, on day 6 actually, it was most of the patients who were hospitalized with COVID-19 and who had been put on remdesivir, most of them were discharged after 5 days of hospitalization and after receiving remdesivir. And this was based on risk disease. And when you look at the peak for 10 days, it was about day 4 and day 11 for when it comes to a 10-day course of remdesivir. So the 5-day course seemed to have better outcomes compared to a 10-day course of remdesivir in our setup. The other conclusion, basically, because this was a pre-specified observational study, and which only was seeking to define whether a 5-day course was better than a 10-day course. And of course, a maximum of 5 days course, 76% of these patients had better outcomes compared to the 10-day course of about 38%. So in conclusion, we would say that the better outcomes for remdesivir and for its emergency use would really recommend for its usage, a compassionate usage in moderately severe cases of COVID patients. And of course, 5-day course, which according to the table on your right, less adverse effects were recorded for a 5-day course compared to a 10-day course of remdesivir. And patients who, if a patient is admitted and does not require intubation, there's no point of going up to the 10-day mark with remdesivir. There's no justification for 10-day dosage of remdesivir without intubation. But if the patient, in case the patient is on supplemental oxygen, then 10-day could be beneficial to those populations. The other molecule or the other drug that we'll look at in this particular class, I'll just go over it so fast because this particular drug has been stopped by WHO. It's no longer recommended by WHO and many other organizations. And as we know, it has so many controversies around it, really. And the pertinent questions to ask is, does SQ really work? If we add azithromycin to it or zinc, does it really improve the outcomes? And as we know, most of the world leaders have pitched for its use, and some of them have come out to claim that they have actually ingested a few dosages for it prophylactically. And we ask ourselves, is it evidence-based or is it just politics? Because we've seen videos after videos, but we in the medicine world, we have to really demystify some of this and read and learn and to find out the best practices and the best outcomes for these particular molecules. We remember this Lancet publication, which actually defined the use of hydroxy, and there was so many backlash against it and for it, of course. But now this is what now shed the light to now having hydroxy being withdrawn from the Solidarity trial. And when you look at the forest plot from this study, which was conducted by the Oxford Center of Evidence-Based Medicine, which was doing the recovery trial, it concluded that there was no, alone or with azithro, hydroxychloroquine did not improve on outcomes, and it did not reduce the mortality rates. But now it's bemusing, really, because recently there's been an observational study which was conducted in Belgium that used a low dose of hydroxychloroquine. I remember the Oxford Center used a dosage of 800 mg and then a start dose, and then 800 mg after 6 hours, and then 400 mgs after 12 hours, quite a high dose really. But now this other study from Belgium, which sought to the efficacy of hydroxychloroquine and mortality in COVID-19 patients, used a low dose hydroxychloroquine, and the conclusion was that it was effective, it was efficacious when you use low dose of HCQS. Now we know HCQS from a long time, many decades. It's a drug that we know. It's a drug that has been used for many maladies, and the ADRs of HCQ, we know them. So the controversy is really around this medication is, does it work? Does it not work? Yes, the adverse effects, we've known them from the beginning, but then we have to really look at the data that is coming out for or against the use of hydroxychloroquine. Yes, in our setup, we no longer use hydroxychloroquine. Of course, owing to the mortality rates, it did not improve any mortality, reduce any mortality rates in COVID-19 patients. Even the Solidarity trial used high dosage of hydroxychloroquine. Some studies in Brazil also used quite a high dosage of hydroxychloroquine. So we need to relook at the data really, which is coming out on HCQS and engage for ourselves, because according to the BNF, the dosage for hydroxychloroquine is between 200 to 400 and a body mass of 6.5 mg per kg. So when we look at the dosages which have been used before were very high, but then what about the low dosage of hydroxychloroquine? Does it really work? Okay, but we know that a combination of hydroxychloroquine together with azithromycin is catastrophic, because both of them have an issue with QTc elevation. So the author conclusion, basically, as we've said, there was a worsening condition of patients when there was a combination of azithro and HCQS because of the arrhythmias and cardiac conduction. So basically for us, we do not, because of lack of good data, because of the controversies around, we are alive to those controversies, and we do not really recommend its use, even prophylactically, because there is a lot of mumbo jumbo regarding this particular drug, and data is we're yet to be informed by proper good data regarding its benefits on COVID patients. So we move to corticosteroids, and recently we've seen reports that dexamethasone has good outcomes when it comes to critical or critically ill patients. And in this study, which was published in the New England Journal, concluded that 28 days mortality was improved in patients who are mechanically ventilated and patients who required supplemental oxygen. And also there was no benefit to patients who who do not require oxygenation. So you can see actually that in patients who are moderately ill, we can give remdesivir. In patients who are critically ill, then dexamethasone comes in handy. In the Journal of American Medicine Association, a meta-analysis of 7 randomized trials, which was conducted, also sought a 28-day mortality reduction rate in the use of corticosteroids compared to standard of care or placebo. But a study, two studies which were conducted to be able to evaluate the efficacy of hydrocortisone were stopped midway, and because they did not meet pre-specified criteria. So the study on hydrocortisone is still pending. It's not conclusive yet, as of yet so far. So some of the questions we ask ourselves is dexamethasone versus other corticosteroids. Why dexamethasones? Now we know, even without even indicating it in this slide, that dexamethasone is cheaply available. That's one, but and also it has a potent anti-inflammatory and weak mineralocorticoid effect. And of course, compared to the others, it has a long biological half-life of about 36 to 54 hours. Now, can we use alternative glucocorticoids such as prednisolone or hydrocortisone? Now, when dexamethasone is not available. Now, data on this, as I've mentioned before, is yet to be conclusive. It's still unclear. Use of alternative glucocorticoids such as prednisolone is recommended, but then data is not conclusive yet, as of yet. Is it safe to use DEXA during pregnancy? So we know that dexamethasone reaches high concentrations in fetus, and we know that low-dose dexamethasone is used in fetal lung maturation when there is an absence of betamethasone. And of course, prednisolone crosses the placenta, but appear in only small amounts in cord blood. So some of the reasons why we can use DEXA as compared to the other corticosteroids. Our recommendation so far is in ventilated patients, it's prudent to use dexamethasone. A 6 mg IV OD or 2 mg IV TDS would work. And in pregnant women who are mechanically ventilated, who require oxygenation, dexamethasone will be beneficial to them. Now, until we have more sufficient data, it's better to use dexamethasone. And of course, in unavailability, we can use the other glucocorticoids. It's better to use the intermittent dosages of dexamethasone rather than the pulse dosing of methylprednisolone. When we move to the immune response modifiers, we look at Tocilizumab, which is currently under trial in many. The Roche is conducting a number of trials on it, and as we know, this was basically brought in because of the cytokine storm. It's an interleukin receptor, and it's a biologic, really, and this particular drug comes in handy when a patient develops, a severely ill patient develops a cytokine release syndrome, which we normally call the cytokine storm. And trial in China, which sought to reveal the use, the benefits of Tocilizumab in critically ill patients, patients who had extensive lung lesions, patients who had opacity and who had severe SORBs due to elevation of interleukin-6 were given Tocilizumab. And we know in our setup, some of the patients have been given this, but then the trials are still inconclusive on Tocilizumab, and we're still waiting for the data to come out. So the dosage is weight-based, can give up to 8 mg. The maximum dosage is 800 mg, which is infused over 60 minutes. And then rarely do we give another dose unless there's no better improvement of the patient. Maximum doses are 4, but we rarely give even 2 doses. Mostly one single dose of Tocilizumab is sufficient. Adverse reactions to look out for usually is the elevation of LFTs and phlebitis in the area of infusion. And we have to monitor renal impairment, which we have to monitor the liver functions. And if they're 5 times upper limit, then we discontinue. But the good thing with this, it's only a single dose. Unless otherwise, we only give a single dose for tocilizumab. If we look at some of the updates surrounding tocilizumab, and we look at the 3 trials conducted by Roche, disappointing news came out from the Covacta trials, which did not really meet the primary endpoint of improving clinical status of patients who received tocilizumab, who had COVID-19. This study was based particularly in the US and Canada and Europe. And in Africa, we had the Impactor study, which was conducted even in our own setup. And the results or the data on this is yet to come out. So we are still looking out for this particular phase 3 clinical trials of Impactor, which was conducted in our setup. And of course, there's a phase 2 of Mariposa trial conducted by the Roche. So basically, we recommend the use of tocilizumab as part of a clinical trial so far in severely ill patients who are experiencing hyperinflammatory effects or syndrome due to elevated interleukin 6. Now, this brings us to what we can do as a society or as a profession. And I'll break it down to 6 elements or 6 key points of what we can do as a profession to be able to improve practice, to be able to inform change in practice, to be able to offer better care to our patients with COVID-19, as whichever setup you are, community care, hospital, management. So as a profession, we have to ensure that there is safe prescribing, besides the usual commodity handling, that is the ordering and the dispensing, but we have to ensure there is safe prescribing, safe dispensing, and we have to keep track of this medication, because bearing in mind the cost implication of some of these therapies, trial therapies. For example, some of the trial therapies like tocilizumab is quite costly, which will cost, a single dose will cost for up to 300 to 350,000 shillings. And that does not come cheap to the patient. So we have to ensure that the prescribing is right, the diagnosis is right, and the infusion, the administration is right. And of course, constant monitoring and reporting of adverse reactions. And the Pharmacy and Poisons Board has set up a very robust way of reporting some of these adverse reactions. These trial therapies, even elevation of the parameter, the derangement of parameters has to be recorded as an adverse reaction, because if we, and the board requires that we ensure that we have constant reporting of all these trial therapies, and that's very good of the board so far. And as a profession, we also have to ensure that there is consent from the patient at all time, because remember, all these therapies are just but investigational. So a patient consent is required. And if a patient is not in a position to give a consent, then the relative is pulled in to be able to give the consent. Now we are in a steep learning curve, information overload, and we have to continue with this steep curve. And we as a profession have to ensure that we are ahead of the curve by learning, unlearning, and relearning, ensuring that we keep abreast of the information that is coming out, churning out from the researchers worldwide, and also some of us, I know they're involved in some of these trials, and to be able to inform, and lastly, to be able to ensure that we share, we take part, we collaborate with other healthcare practitioners to share this knowledge that we have regarding some of these trial therapies. Now, to conclude our session today, I'll take you through this particular case study of a patient who was about 35-year-old male patient, weighing about 85 kilograms, who came in as a referral from other facilities with a 3 days history of cough and SOBS, that is obstruction, and then HRCT, which showed opacity, that is glassy or cloudy-like of the chest, and the pulse was about 94 and the BP was about 120. He was saturating at 95. The D dimers were crazy elevated. Their lefties were normal all through. The glucose initially, the sugars initially were normal, but they were elevated at some point. And the end diagnosis was critical COVID-19 patient and type 1 respiratory failure. Okay, sorry for that. So some of the medicine that this particular patient received, the slide seems to be missing, but then this patient was never intubated. He received about 9 doses of remdesivir, and he received a single dose of tocilizumab, considering his severe SOBS and persistent cough, and of course the other standard of care. So up to that point, I beg to finish and hand over to my colleague, Dr. Kagwa, to just share a bit about taking care of chronically ill patients with COVID-19. Thank you very much for listening to me. Back to you, Chair, Dr. Mugoma. Thank you. Asante sana.
Thank you so much, Dr. Ruben Mugoi, for that insightful presentation. I really enjoyed the pharmacology there and the details about the various treatments that are there, and the focus on just reminding people that we do not have a cure for COVID-19, but as medical professionals, we are managing these patients or these cases. I want to move on straight to Dr. Kagwa Gichuki for the sake of time. So, Dr. Kagwa, please go on. Dr. Kagwa, please share your slides. They were up there a few seconds ago. Yep, and you can put it on PowerPoint slides. Just to remind everybody else to send in your questions through the Q&A tab. Thank you. Go ahead.
So, Teacher, Dr. Mungoma, good morning, everyone. My name is Dr. Kagwa Gichuki, as had been introduced. So I just want to share something, or maybe the updates that are there regarding the management of chronic illnesses with a comorbidity in COVID-19 era. So this has been mentioned before, but now I think the new thing that has come up here is that after genetic sequencing of the virus, it suggests that it's a form of a coronavirus called a beta coronavirus, which is closely linked to the SARS virus. So that as we delve more into our special population, which I intend to cover in diabetes, hypertension, and end-stage renal disease, it's good for us to have an understanding on how COVID affects our bodies, or the pathophysiology. So basically, as we mentioned in other forums, the entry point of the virus into our bodies is the angiotensin enzyme 2 receptors, which are spread across our bodies in the various organs, the brain, majority are in the lungs, the heart, the pancreas, the intestines, the liver, and the kidneys. And perhaps this can explain why, apart from the severe pneumonia that is being reported, some patients are presenting diabetes, especially DKA, that maybe explain the presence of the ACE2 receptors in the pancreas. There are some few patients who are also reporting of GIT diarrhea issues, maybe because of the receptors in the intestines. And most of the patients who are developing severe COVID disease are requiring dialysis. And that may be because of the ACE2 receptors in the kidneys. So what happens when the virus gets into the body? So this slide is a busy slide, but just in summary, there are phases of the infection. So when it comes, it's an airborne disease, of course. So most of the time it will land in the lungs or in the intestines. So in the phase 1, there's infection of the epithelial cells. So these two receptors in the lungs or in the GIT, they become infected. Then there's production of cytokines and chemokines. Then from there, now the body reacts to that infection. So there's production of neutrophil, macrophages, all those cells and enzymes involved in the immunity. So the phase 2 is acute inflammation. Now, in phase 3 is what determines if your body is able. If you look at the left side, if the immune cells are able to contain the virus, then you get resolution. That is antiviral immunity, and then subsequent suppression of the hyperinflammation. But now, in worst case scenario, in case now the inflammation overcomes the immune system, that's when now you go. This what has been mentioned by Dr. Mogoi about the cytokine storm syndrome, the neutrophilia, monocytopenia, and lymphopenia, and that's when now you develop the severe COVID-19 disease, which is presenting with acute respiratory distress syndrome, shock, kidney injury, organ failure, and secondary infection. So just according to CDC, there are those, due to the ongoing studies, initially we couldn't say for a fact whether some conditions were risk factors or not, but the recent data we have from CDC, the established risk factors include cancer, those who are at risk factor of contracting, especially the severe form of the COVID-19, cancer, chronic kidney disease, COPD, immunocompromised state from solid organ transplant. Those who are obese are also shown to be more prone to the disease. Those with serious cardiovascular diseases such as heart failure, coronary artery disease, cardiomyopathy. Sickle cell disease is also an established risk factor, and type 2, diabetes mellitus. So there are those that they are showing a strong association, but it has not been proven. The data that is available is not yet conclusive of the established risk factors, so they are being classified as possible risk factors. Asthma, especially the moderate to severe form of it. Those who have encountered a CVA, cerebrovascular disease. Those with cystic fibrosis, hypertension, and high blood pressure. This one is a bit controversial. There are some studies that are saying definitely it's a high established risk factor, but there's still some controversies. But even in our setup, we have seen people with hypertension they tend to get a more severe form of the SARS-CoV-2. So also the immunocompromised state from hematopoietic cell transplant, those who have HIV, patients on chronic use of corticosteroids and other immunosuppressive agents. Those with neurological conditions such as dementia have been shown to be possible risk factors, liver disease, pregnancy also, pulmonary fibrosis, those who smoke, thalassemias, those are type of blood disorder. And now here's the interesting part. So type 2, we have seen type 2 has been established as a definite risk factor for severe COVID-19. Type 1, the data does not yet still classify it as a definite risk factor, but it's a bit controversial. So it's going to be a brief, just to give you an update on the management of these chronic conditions, and I'm going to concentrate on these three special populations, those with DM, hypertension, and end-stage renal disease. So the recent data we are getting on diabetes, especially those who get now, we are talking about patients with diabetes and then who contract COVID-19. So as regards the use of oral hypoglycemic, they have been shown they can cause volume depletion or hypoglycemia and they should be avoided. Once the patient contracts COVID-19, it's advisable to stop. And use of medicines that may increase the risk of hypoglycemia, such as sulfonylureas, and drugs that may mask the symptoms of hypoglycemia, such as beta blockers, is highly discouraged, according to that guidance statement. So metformin, of course, is a first-line treatment for diabetes in our setup and across the world. And we have new entrants into the market of the sodium glucose transporter 2 inhibitors. They are in the market now. We have examples of canagliflozin. And they have been, the data that we have, especially from the diabetes UK front, though they give regular updates, they have been shown if a patient has been on these medications and then they develop severely ill COVID-19, they are advised to be stopped. Why? Metformin has been shown to cause lactic acidosis in patients who contract COVID-19. And those on SGLT2 inhibitors, remember they promote they lower the threshold of the kidneys to excrete glucose in our urine. But paradoxically, they have also been shown to increase the risk of DKA. So a patient on it, they are advised to be stopped. And this is especially so in patients who are lean with type 2 diabetes, and even some patients with type 1 diabetes who are on off-label SGLT2 inhibitors. Yeah, some patients with type 1, they are being put on these sodium glucose transporter 2 inhibitors to help them attain optimal glucose control and also to reduce their insulin requirements. But these issues of DKA and lactic acidosis have been shown in such patients. So for both drugs, the metformin and the SGLT2 inhibitors, both of them show increased risk of acute kidney injury, which can progress to CKD. So what do we do? For those patients who have not yet developed, there's still controversy. For those who have not yet developed a severe form of the disease and they're still on these drugs, or those who you have stopped because they have contracted the disease, you need to do close monitoring of the renal function in these patients. But in type 2 diabetes mellitus and latent autoimmune diabetes in adults, the SGLT2 inhibitors have been shown they can still be maintained, but you have to closely monitor the renal function and the hydration status of the patient. So if you have to maintain the patients on these drugs, the type 2 diabetic patients, and you still want to maintain the SGLT2 inhibitors, you must ensure that the patient is able to test for ketones frequently at home, and not only in urine, which we are challenging our setup, but the data, the evidence supports ketones in blood too. And also the patient is able to hydrate well for them to continue being on these drugs. So, but however, they should not be discontinued prophylactically in outpatients who do not have evidence of COVID-19. But in any case, hospitalized patients with diabetes and COVID with severe disease require frequent blood monitoring, glucose monitoring with a target blood glucose of 6 to 10. In the normal setup, in the absence of COVID, our target is normally 11.1. But in the presence of COVID, our target is a bit lower, it's 10, it's not 11.1. So what does data say about the use of insulin? So for patients who contract, especially the severe form of COVID-19, insulin is the preferred agent for control of hyperglycemia. So as we have seen, the issue with the oral hypoglycemics, the risk of dehydration, the CKD, the acute kidney injury. So insulin has been shown to be the best. In case a diabetes, even if the patient was not on insulin and then they contract COVID-19, it's advisable to switch them to insulin. And when I talk of insulin, they are what we call the basal bolus regimens are the ones that are recommended over the pre-mixed insulin. What we mean by the basal bolus insulin regimens, maybe this will try to shed some information. Basically, basal insulin is the insulin that the pancreas makes when you're not feeding, or to keep the blood sugar normal when you're not eating. Then there are those bolus insulin, that the insulin that the pancreas sends out in response to food, or when you have spikes in blood sugar. But if the patient is nil per oral, is not feeding, or has not in any, you do not have to administer the bolus insulin. So sometimes in our setups, we have to, even if you give basal and bolus, you still find the glucose is not yet within the optimal control. So we have to give some additional doses of insulin, which are they're being termed as correction insulin, given for high blood sugars, often in addition to bolus insulin. And this is what I'm talking about. So instead of using the premixed insulin are the Humalog 70/30, Mixtard. So those ones have been shown not to quite well control the sugars, because you want to maintain the sugar optimally 6 and 10. So the red waves represent the short-acting insulin. So when the patient has had breakfast, they take a short-acting insulin, like insulin aspart or glucosamine, or in our setup, regular insulin. So whenever they have lunch, because of the spike in glucose levels, they also take another dose of a short-acting insulin and supper. So this one is a long-acting insulin, the basal dose, something like insulin degludec, they're in the market. So, and most of them, they can be given once in 24 hours, just to maintain the basal insulin when you are not eating. So this way of controlling blood sugar has been shown to be the best. The available evidence supports the use of basal bolus insulin regimens instead of the premixed insulin regimens that we have in the market. So as regard the use of insulin pumps, of course, they will be the best, because now the body, you adjust them, then they are set to sense the blood sugar levels. Wherever they go up to a certain limit, the pump comes on, or whenever the glucose level go down, they shut off. But now the issue in our setup is that when you have patients in the isolation areas and they are on insulin pumps, somebody needs to keep on checking their blood sugar, because sometimes they are not that conscious, or they cannot monitor the sugar themselves. So that in our setup will prove to be an issue because of the issue of shortage of PPEs. Remember, when you go into the isolation center with a PPE, once you come out, you have to discard it and use a fresh one. So all in all, whenever you're using insulin regimens in these patients, you have to keenly monitor the potassium levels in the context of insulin treatment, so that you don't get the issues of hypokalemia, which might be catastrophic to the myocardium. So what does the evidence say about these new drugs? These are the glucagon-like peptides, one antagonists. I think the ones that are in the market at the moment are the injectable exenatide, liraglutide. And then we have DP4 inhibitors, which have been shown to really reverse the course of diabetes in our patient. Example is sitagliptin, vitagliptin. So what does the evidence say as regards their use in COVID-19? So they can, excuse me, they can still be continued in diabetic patients who contract COVID-19. And patients on GLP-1 agonists should be carefully monitored for dehydration, and adequate fluid intake and regular meals should be encouraged in such patients. What about the use of statins? We all know for patients with diabetes type 2, aged between 40 and 74, according to the studies that have been done, regardless of the lipid levels in this patient, whether they have hyperlipidemia or not, we usually put them on statins, atorvastatin, rosuvastatin, or anyone. But in our setup, I think in the public sector, I think what we have a lot is atorvastatin. So we usually put them not just because of the lipid lowering effects, but because of the long-term benefits, what we call pleiotropic effects of statins. And which are these pleiotropic effects? So apart from the lipid lowering effects, these are additional benefits that they were not intended for when the drug was being released, but they have been shown to occur when the drug is used. So when you give statins in diabetic patients, they have been shown to improve the endothelial dysfunction. They have been shown to increase the levels of nitric oxide. They have been shown to act as antioxidants. And of course, they have been shown to reduce the platelet aggregation. So they are beneficial. So we put patients with diabetes on that because of that. And then, so even in COVID, the data still suggests we still maintain them on the statins. And another critical issue is that it has been shown that there's a potential for tipping the balance towards the cytokine storm by rebound rises in interleukin 6 and 1 beta if they were to be discontinued. Dr. Mogoi mentioned about the cytokine storm. This is just to maybe to briefly to state what it is. So then in normal conditions, the angiotensin 2 binds to the S2 receptors. And we have said the SARS-CoV-2 infection are using the S2 receptors to get into our bodies. So when they get in, there are these inflammatory markers. This is a long process. I'll not expound on it. So you block the angiotensin 2 outside. So the virus enters the body through the S2 receptors. Then there is activation of the chemokines and cytokines. Our special concern is the interleukin 6 and AMP, but it's a complex mechanism where at the end of the day, you have a storm of inflammatory cytokines. And this is mostly what is being seen in patients who are developing the severe form of pneumonia, the acute respiratory distress syndrome. So lipid statins have been shown to, if you withdraw them, you might tip the balance toward the cytokine storm. So it's advisable, going by the data available, we still maintain the patients on the statins, even if they contract COVID-19. So what about hypertension? So according to our setup, it has been shown to be a poor prognostic factors in patients who contract the SARS-CoV-2. And initially, there were, especially in the month of February, March, April, there are many concerns about the use of RAS inhibitors. You know, they are very effective drugs in the management of hypertension, and also because of the fact they are renoprotective. So there was an initial concern that continued use of such drugs in the presence of COVID-19 will make a person more vulnerable to disease or the severe form of the disease because of the upregulation of the S2 receptors. But some studies that were done consequently, I'll just discuss this one done in China, where hospitalized COVID-19 with hypertension and on treatment with RAS inhibitors had significantly better survival compared with similar hypertensive patients not on these drugs. That was in an observational propensity score matched analysis that do from a pool of more than 3,000 patients hospitalized at any of the 9 hospitals in China during that period. So consequently, other studies have come, even some societies have come up to support the use of RAS inhibitors even in the presence of COVID. The use of angiotensin, the ACE inhibitors and ARBs should be continued. Evidence to date is reassuring on this issue, and all major cardiology societies recommend patients to remain on these agents. So just additional information or data to support that. So available evidence does not support discontinuation of renin-angiotensin system as antagonists, including the ACE and ARBs, in patients currently treated with such agents. The issue here was that if the patient is currently on those drugs, the data does not support stopping. But now the controversy arises where if the patient has not been on them, then he's hypertensive and then contracts COVID-19. So we still don't have concrete data as where you can initiate the RAS inhibitors in such patients. But if the patient initially were on it, there's no data to support the withdrawal of the same drugs. So an earlier study had even shown that these inhibitors and ARB, they were shown to reduce the inflammation, the severe lung injury in animal models. So as regards hypertension, basically the guidelines say the usual antihypertensive should be continued even in the presence of COVID-19. So, but however, for those patients who develop septic shock, it's recommended to stop the antihypertensive until you sort the issue of shock, especially septic shock. So some studies have been done as regards the other drugs used for medicine used for hypertension, beta blockers, calcium channel blockers, statins, thiazide diuretics, and they have not been associated with an increase of COVID-19 or any worse outcomes in patients with COVID-19.
Dr. Kago, I'll rush you a little bit, 5 minutes. Thank you.
I'm just coming to the end. So just rush to, so for those patients who are on dialysis or stage 5 renal disease, end-stage renal disease, the evidence says the patient should remain on the medication at prescribed doses, including ACE inhibitors and ARBs, unless indicated otherwise. So you should not change the doses that they have been on. But of course, when they are on ACE, you have to monitor the potassium levels. So now we go to patients who have undergone a transplant. So the guidance supports you stop immune suppressant to promote an antiviral response. but you maintain the steroids as the only anti-rejection drugs. Then they talk about you reduce the dose of steroid to equivalent of a prednisolone dose of 0.2 milligrams per kg per day if possible. But in case the patient develops leukopenia or lymphopenia, you reduce the dose of the cytotoxic drugs until the WBCs recovers, so that the patient can be able to counter the infection, because lymphopenia might be a sign of active COVID-19. So for going on for renal transplant patient in the presence of hypogammaglobulinemia, so you can consider replacing that using immunoglobulin G given intravenously to protect the patient from secondary infection. So the ACE inhibitors and ARBs can still be used in patients who have undergone transplant unless there's acute kidney injury. So for patients with mild or no symptoms and then they have undergone renal transplant, you might consider stopping or reducing they normally get antimetabolites, calcineurin inhibitors, and steroids. So the data suggests that you consider stopping or reducing antimetabolites, including mycophenolate mofetil and azathioprine, but you avoid stopping the steroids abruptly. Calcineurin inhibitor or cyclosporine has been shown to reduce the virus replication. But if you are planning to do a cyclophosphamide or rituximab infusion, it's good to postpone until the patient feels better. So for patients who have been admitted with pneumonitis and with COVID-19 and they have renal transplant, we withdraw mycophenolate mofetil and azathioprine and calcineurin inhibitors and mTOR inhibitors, especially sirolimus. And you replace all that therapy with methylprednisolone at 16 milligrams per day. So as pharmacists, I just borrowed this from the Malaysia National Medicine Policy. Basically, this is our role. In our hospital setup, we're ensuring the quality use of medicine, especially this one, the quality, safety, and efficacy. Mogui mentioned about the affordability, the side effects. We really have to monitor that. Of course, the other pharmacists now in the regulatory authorities, they have to do the governance issues in medicines. Those in industry, we have to partner with them in terms of partnership and collaboration for the healthcare industry. And those in healthcare, especially pharmacists, is our role. Like we are always incorporated in the COVID response teams in our hospitals, especially because to ensure access to medicines, we have to quantify what is needed, which drugs are supported by evidence in our setup. So that's our role, to ensure the one that are really supported by evidence in our setup are the ones that are really, we ensure they are accessible to our patients. So I want to stop there. Thank you very much. Asanteni sana.
Thank you so much, Dr. Kagwa, for that and keeping time there. You actually used 3 minutes out of the 5 that I had proposed to end. But I must say that pharmacists are really doing quite a good job out there in clinical practice. And the two of you, Dr. Ruben, Dr. Kagwa, are a clear indication. I want to go straight to the Q&A. And I want to start with, so there's an anonymous person to Dr. Kagwa. Is there data available on association of age and hypertension relative to COVID morbidity and mortality? Specifically, are young hypertensive patients in the absence of obesity equally susceptible?
So,
Dr. Kagwa, yeah.
So first of all, even in the absence of COVID, we know age is a risk factor for hypertension. But initially, the thing with COVID-19 is that data keeps on changing daily. Dr. Mogoi said about learning, relearning, and delearning and learning again. But yes, for the older patients, and especially with hypertension, there's been shown to be there's a tendency for them to develop a severe form of COVID-19. For obesity, yes, as I showed in the slides by the CDC, obesity has been shown to be a risk factor for developing a severe form of COVID. And of course, obesity is also a risk factor for hypertension. So the data that is available, but more is still coming in, supports the issue of age, obesity, and hypertension. They are risk factors for developing a severe form of the disease, if not contracting it in the first place.
Thank you, Dr. Kagwa. There are quite a lot of questions, but we are just going to pick a few of them. Dr. Ruben Mogoi, the question is, are the communications around treatment of COVID-19 effective or misleading? Comment on that.
It's a jungle out here of information, and you have to do a lot of reading and filtering through and through to ensure that the sources that you're using to pick this information is credible sources, because you can get information from anywhere, but you have to ensure that you pick information from credible sources so that you don't fall prey of the misleading out sources, because there could be sources which would want to politicize information, which would want to kind of really mislead the populace on some of this information regarding COVID-19. So we have to be really careful on how we pick our information sources. Thank you.
All right, thank you for that. Yeah, there's quite a lot of, and that's part of the problem with this pandemic, is that a lot of people out there are just talking or sharing information that really requires quite a bit of keenness just to make sure that you're not getting lost. Dr. Kagwa, in your practice or in your setting, are there patients demanding for medicines that they have heard of or read of? Because that's the other problem that we are facing.
Dr. Mungoma, I don't get the question, please.
So what is happening is that information about medicines for treatment, management, or drugs or substances out there that could address COVID-19 are just being shared, whether it is social media, internet, wherever people are getting through emails, through the newspaper. Do you have patients in your hospital demanding for medicines that they have heard of or read of regarding COVID-19?
Okay. First of all, in our county, most of the patients, if you get a positive patient, there are several centers in Kiambu County. Like in our case, we are referring them either to KU or to Tigoni. So, but apart from a patient, I've received personal calls or inquiries about, can I take hydroxychloroquine for prophylaxis? Can I use lemon and ginger as prophylaxis? Is it working? I've heard that. But
how are you managing those type of clients or patients?
So I think one of the crucial roles for pharmacists is educating the public or the community information about the medicine. So it's very, you try to tell them like hydroxychloroquine, especially with what they came from the Twitter, from the States. That week, there was a lot of hype for hydroxychloroquine being asked around, even in community pharmacy. So it's my role to tell them this drug has not yet been approved. It's just a trial drug. The studies that are coming out are not showing any beneficial effect. So it's just a matter of educating. Of course, some of them will insist on getting it, but from professionally, you advise them against such self-medications, which might even end up hurting them, like with the liver issues.
Yeah, I think that's very important, because again, when you're handling the public or handling clients out there, they tend to look for options, yeah? And what happens is that if you remain professional, then you're likely to handle these patients better, unlike people who just want to see how best to give out. And there's actually even somebody who's commenting or asking the role of vitamin C, because there are a lot of people out there now selling supplements or distributing and making claims behind some of these products to be very, very effective against COVID-19. And some of the information is quite misleading. Still, Dr. Kagwa, there is Amina Ndope who is saying or asking, are insulin levels measured along with glucose levels, just so we are not increasing insulin to very high levels in an individual with severe insulin resistance?
Personally, I've not come assess the levels of insulin in the body. And what we measure currently are the blood glucose levels and, of course, the ketones. And I've not had, I'm not aware of a test that, insulin is a protein. So once it has done its work in the body, most of the time it's digested. But personally, I've not come across of a test of measuring the insulin levels in the body. What we do is relate the sugar levels. But now the issue is that even in the absence of COVID, there are those patients with type 1 I've encountered that require very high levels of insulin. They develop what we call insulin resistance. Nothing much can be done about those patients. You just have to keep on increasing the dose of insulin and do as much as you can.
Okay. Dr. Ruben Mogoi, you talked about various medications or forms of treatment or pharmaceutical management for COVID-19 patients. How do we manage adverse drug reactions associated with steroid use among COVID-19 patients? Yeah, because again, we've noticed that a lot of medicines that have been proposed or are being used for the management of COVID-19, pharmaceutical care really needs to come in. Pharmaceutical practice needs to come in to ensure that, you know, these patients are monitored also for ADRs and not just focusing on whether the viruses are going down, whether the prognosis is moving as expected. And it's not just steroids, but also these other drugs that you mentioned, Tocilizumab, yeah, because there's a claim, in fact, there's a publication that says there's drug-induced liver failure under therapy with Tocilizumab that can occur even after years of training, treatment, not training, but treatment. So how do we monitor that in this pandemic, steroidal use and all the other drugs that are available?
Good question right there. If you can remember, I mentioned that the steroids we use, if I could actually even take you to the slide that is on your screen right now, this is from our patient that we talked about. The patient here was given 2 mg IV TDS of dexamethasone. So in regards to your question, it's very critical for pharmaceutical care to be well taken care of. And we as a pharmacy profession, we have to constantly ensure that we check the labs. One of the side effects of steroids, long-term use of steroids, is actually hyperglycemia. And we've seen hyperglycemia in COVID-19. But the good thing with these dosages for these trials, something like the corticosteroids, we're ensuring that, or even the doctors themselves, ensuring that they're using the lowest possible dosages and for shortest possible time. Like you can see for dexamethasone in a setup, in a hospital setup, would be given basically for at least 5 days, and rarely will go to up to 10 days in a very low dosage. And they will use the intermittent corticosteroids. That's why we are insisting on the intermittent, including the Dexas, and much so no data really, as I indicated, that 2 data on hydrocortisone have been stopped. They didn't meet the pre-specified outcomes because they are, for those ones, they require the pulse dosing that you have, because when you're given a high dosage of those particular drugs, they're required to be pulse dosed so that the side effects are minimized. But now, when it comes to Tocilizumab, yes, one of the key uncommon side effects that we have to look out for is elevation of LFTs, or in the long run, the effects on the liver or liver failure. And the good thing in our setup, we have to give only just a single dose of Tocilizumab. But as I said, the trials are still ongoing and the data is still conclusive. The first trial, which was Convacta, did not bring good news because it did not really meet the objectives. The patients did not improve in any way after receiving a single dose of Tocilizumab. So as a pharmacist profession, we have constantly check on the patient and check on patient labs and see how they're doing. And if in case, as I mentioned before, we see an elevation, a slight elevation of the parameters, then we inform the primary team, and then the team can relook into that and then consequently stop or change that particular therapy. Back to you.
Thank you. I think it's so important just to remind our colleagues, especially those that are working in hospitals, that this is a very important time for them to really apply some of the knowledge and the skills that they acquired in school, particularly medication therapy management and just monitoring of, whether it's long-term toxicity. It's looking at patients who are on these medications, whether they're undergoing critical care or otherwise, and being able to follow up these patients, because they can come up time later with reactions or complications, and we need to be there to connect the dots. Was this related to the treatment that they were given at the time? Dr. Yakub is commenting there and saying that we are dealing not only with a pandemic, but also an infodemic. And that is what Dr. Ruben has just reiterated there. There's lots of information that is coming out, and we need to be very careful as we filter information, not just as professionals, as well as members of the public. I want to appreciate the two speakers, Dr. Kagwa Gichuki and Dr. Ruben Mogoi, for their time today to come and share with us their COVID-19 experiences out there as pharmacists, specifically as clinical pharmacists in their facilities. And it's so important for us to know that there are people doing things out there and that we are connected as a sector. I also want to appreciate all the other cadres that are present this morning, the pharmaceutical technologists, nurses, or other cadres that have joined us this morning for this webinar. I think it has been a very informative webinar. I want to insist on following the Ministry of Health guidelines. We are well aware that we are possibly, or some of us are already suffering COVID-19 fatigue. And part of that is, part of the signs and symptoms of that is that some people no longer believe what is happening. Some people are not following these guidelines strictly. Some people are probably even just taking part in misinformation. So it's important to continue following these guidelines that are out there. Three of the most important ones are social distancing, washing hands, again with running clean water. And I keep insisting on this particular point because we have all these tanks or all these vessels that are outside our facilities or sometimes inside our facilities with water that has been stored there. And if it is not a very busy place, whether it's an office, a corridor, or outside that facility, that water can stagnate there for days and days if nobody is designated there to ensure that the water is replaced frequently, so that we don't end up washing our hands with water that will now probably keep us away from COVID-19, but now will introduce other forms of infection, including providing breeding grounds for mosquitoes and other forms of pathogens or infectious agents. Use of masks, again, let's keep up with the use of masks and ensuring that we're wearing our masks properly, covering our noses and mouths, and not just wearing for the purposes of being part of the whole process. And wherever we are, let us be able to share correct information. Being able to do this means also that you keep up with information and that you're able to source information from authentic sources. Yeah, so whether it's WHO sites or CDC sites or Ministry of Health sites, that you're able to get correct information and that you're able to share this correct information with people out there, public, in ways that are well understood. Yeah, so for purposes of getting everybody to address this pandemic. I want at this juncture to again appreciate everybody who has been able to put this webinar together. That is the CEO, Dr. Daniela Munene, and Mbao, who has been very good with the slides. Mbao, maybe you can just put the slide with the call for abstracts so that I can just say 1 minute. So the Pharmaceutical Society of Kenya, put it on PowerPoint, please. The Pharmaceutical Society of Kenya is going to have its 40th annual scientific symposium. And this is going to be a virtual edition where the theme is pharmacy delivering primary healthcare, responding to emerging healthcare dynamics. So there's a call out there for abstracts that is open, and the deadline is Friday, September 15th. Let us all try and subscribe and support this conference. We are working in very different times, and we just need to keep up differently. At this point, I want to pass on the microphone now to Dr. Daniela to close this meeting. Thank you.
Thank you, Mike. And thank you, panelists, our speakers, for your very insightful presentations. Thank you, participants, for the engaging session. I think the call for abstracts, Mbao, if you could just go back so that I can read out the sub-themes. The sub-themes of our conference, along which your abstract needs to be aligned, is primary healthcare, health products and technologies, digital health, research and innovation, role of pharmacists in COVID-19 era, and healthcare as an investment. So that's just what I wanted to add. And look out for, in our social media channels and on your WhatsApp groups, even on your SMS, for the link to register for the conference, for the virtual conference. Otherwise, I'd like to bring this session to a close, and we hope that you can join us next week at the same time for a continuation of this series of pharmacotherapy of COVID-19. From PSK, it's a good day to you all. Thank you.